Welcome to Insane Ambition, a business and tech show breaking down lessons and playbooks from the world's most ambitious founders, investors, researchers, and changemakers.
We'd like to thank Melbourne Connect Co-working, Melbourne's most innovative co-working space, for proudly sponsoring this episode. And with that being said, we hope you find this one valuable. For anyone that isn't aware, just for the podcast, any of the listeners listening in today, today we have Professor Jane Gunn, actually a distinguished academic clinician at the University of Melbourne, and also has been bestowed the title of Officer of the Order of Australia. So you're our first AO that we've interviewed on the podcast, and that was given to you in recognition of your outstanding service to the community and achievement. So, yeah, we're really lucky to have you on, and welcome to the podcast.
Well, thank you. It's great to be here today.
Absolutely. So, Jane, tell us a little bit about yourself. What are you currently doing in your life?
Currently, I'm Dean of the Faculty of Medicine, Dentistry and Health Sciences at the University of Melbourne, and that's a very large faculty and makes up about between 60 and 70% of the university research effort, which is enormous. As well as playing a very large role in education. So it's a very large faculty, and it's made up of lots of different schools. So we have 6 different schools: a medical school, one with biological sciences, sort of biomedical sciences approach, looking at population and global health, health sciences with all the allied health disciplines, a really complex medical faculty. So broader than medicine itself, and also really engaged in research, and that spans out across everything from lab-based discovery research all the way through to health policy translation into the community. So it's a very broad faculty with a large number of academics and professional staff, and many, many, many partnerships with health services and medical research institutes. So it's quite a large enterprise.
Sounds stressful.
Well, it has its
moments.
It's
very large, and there's a lot of people involved, and I'm responsible for them.
Well, I'm very, very fortunate to have an amazing team that work with me, and really I think it is large, and at times these sorts of roles can be stressful, but we're very, very well supported, and also we have, we're in a very large university with lots of expertise. So it's a great job, and it's a real privilege to actually to be in the position, because it is such an exciting time, for health, and a challenging time as well. So plenty to keep me busy.
Absolutely. I think one of the main reasons that you promoted to the positions that you have is some of your extensive work in healthcare and some of your research as well that's led to changes in the Australian healthcare system. Been involved in shared maternity care, and then the cervical screening program, and mental health support through the primary healthcare. Maybe you can tell us, our audience, a little bit about some of the research that you've done and what effect that's had in terms of system.
Sure. So I'm a general practitioner by background. So that means, I'm a generalist, and that's quite unusual in research in a way, because often research is about really specialising in a particular area and looking in depth. And, the thing that I've specialised in has been generalism, which, maybe that's a tautology, but generalism as a concept, I think, is a really, really interesting one, and one that can bring and shed a lot of light to a whole lot of problems that we face. And so I'm a firm believer in the fact of we need very highly specialised and technical areas, as well as bringing generalist expertise to problems. And so the areas of work that, I've been involved in have really been at the applied end of research, and it's been about trying to make things better for people when their experience of healthcare. And that has been everywhere from cervical screening, maternity care, and over the last sort of 20 years, a very strong focus on the importance of mental health, but also the concept of what we call multi-morbidity. And I'm very interested in the mental physical interactions that drive people's experience of health and well-being and illness. And that's just fascinated me for a very, very long time. And so whatever, particular piece of research that I might have been involved in, that's what I'm bringing to that problem and really trying to think about it from a generalist perspective and from a whole person perspective. And that's kept me pretty busy, and because, we have many, many problems to look at in healthcare, and bringing that generalist lens has been one that has been quite sought after. And, for many, many years, I think, we've had a very small general practice academic community, both here and internationally. And so there's been lots of opportunities to get involved in all sorts of research, which has been a lot of fun.
Fascinating. I suppose the thing on my mind is, as a general practitioner, being involved in research, did you originally intend to get heavily involved in research, or were you more interested in the clinical side of becoming a clinician?
That's a really great question. I was very, as a medical student, really loved most of the things I did. So I enjoyed almost every topic. I wouldn't say absolutely every part of the medical course, but almost every part. And especially when we got into the clinical years, I really enjoyed what we were doing, centering around helping patients and their families. So I was very, keen on lots of different things. So emergency department care I loved, obstetrics, I loved paediatrics, I loved psychiatry, I loved my general practice term. And so when it came to decide what I wanted to do, I sort of went through a process of all the different areas I'd like to go into, and landed on the fact that probably the thing I most wanted to be was a GP obstetrician and practice in the country. Now, I'm not a GP obstetrician and I'm not practicing in the country. So even though that, if you'd been speaking to me in my final year of medical school, that would be what I would have said I was, wanting to train for. So what happened? I prepared myself for that career pretty well, and I just completed my diploma of obstetrics, which was fortunate to do that in a community hospital called Panch, which is now no longer there. It's now been shifted to the Northern Hospital out in in Epping. And that was a really busy term, and we'd had lots and lots of very long hours, 100-hour sort of shifts, that kind of thing. It was back in the old days. And I was, having a bit of a time off over January, and I saw a little ad when we used to look in the newspaper on a Saturday and look for jobs. And I was also had a bit of a flick through what jobs were available, and I saw a position being advertised at the University of Melbourne in the Department of Community Medicine for a 1-year academic post, which was part of the Victorian government scheme, actually, to support various special skills type posts, one of them being community medicine. And so I thought, gee, that would be a really interesting thing to do. I really loved teaching and being engaged with medical students when we had them on the wards and things, and I really loved medical education, come from a long family of educators, and thought, well, give that a go. It looked really interesting, bit of research, bit of education, but I went mostly for the education side of things. When I started that job, it was 1 year, but I was very, very fortunate to have some amazing mentors there. The person who employed me was Professor Doris Young, and she's an absolute live wire and real inspiring person as to things that were possible to be done. She linked me up with a younger academic there, and Jacinta Halloran, who became my mentor. And within about 4 weeks of being in that new role, I was actually part of a research program which was looking at shared obstetric care. And I was starting to think about how I might go and interview GPs about shared care. So it was just straight off into this research project as well as into medical education. And by the end of that year, I had just caught the bug. I loved the environment. I loved the conversations that were there, meeting all the academic staff, being involved in a really multidisciplinary environment, which was the then Department of Community Medicine. And I never left. I then went on to do my PhD. I did leave for a little while and then come back, but that was it. So the idea of being the GP obstetrician was sort of still there, but it never came to be. Instead, I worked as a GP in the city areas and did shared obstetric care and had a great interest in women's health and paediatrics and mental health in my clinical practice, but never really went and did the GP obstetrics in the country.
Interesting story.
Absolutely. Oliver and I, we just got back from the US, so we're very appreciative now of the Australian healthcare system.
That's an understatement.
I got a blister on my foot while I was just walking around New York, and I looked at the doctor clinic. I was like, oh my God, I actually might not be able to afford to go to a doctor here. And so I'm back, and we're very appreciative of the healthcare system. And one of the interesting things that I think is interesting about you is that you've witnessed a lot of changes that have happened to the Australian healthcare system ever since, your research started and all the way until now. What do you think has been like the main good changes and also bad changes? Where do you think it's going from here?
Well, the good changes, start with a positive, has been some of the amazing progress made in medical care at the super specialty end. And, just some of the advances that we have in cancer care are just remarkable, from when I was a young doctor, where there would be giving news to people about diagnoses that were really, really life-ending. And now they're not. So, for example, breast cancer would have been, when I was a young doctor, telling someone they had breast cancer would be like, well, this is a really, really serious thing, and, 5-year survival rates were not that great, and there was a lot of terrible treatments to endure, and it was very much doom and gloom, whereas now a breast cancer diagnosis really is almost being considered as a, not quite a chronic disease, but not far off it, so it's just so much more hopeful. Likewise, childhood leukemia, things like that have really completely changed. So that area, and new, cell therapies and amazing gene technologies and all of those things are just really been fantastic to watch and wonderful. So that's been great. The downside, I think, has been the falling away of recognising the importance of a very, very strong primary care part of the healthcare system, and the sort of putting down of the primary care setting, like, oh, that's not really a great place to go and work, it just losing the shine on what was actually, from the community's perspective, is a very, very important part of the healthcare system and very, very highly regarded. Even, when I decided to be a GP, it was a very, very common desire of the students that I went through final year and went through, intern and second year post graduating, that it was really hard to get into the family medicine program. And it's just like that's changed in my lifetime. And I've seen the lack of recognition until recently, when everyone's realised, goodness me, this is not, we need to have a good balance in the healthcare system. And if we're going to be able to afford and deliver really the best medical treatments we possibly can in an equitable way, then we must invest and have a very, very strong primary care system. This is something we've said, the leaders in primary care have said for years and years and years and years to anyone who would listen, but it has not really been taken seriously until quite recently, when we now realise that we are in a bit of a crisis. Not so much with the numbers of people that we train, whether they're doctors or nurses or allied health, but where with the distribution of where they're working and what they're doing, it's out of whack. So we have to do something to fix that, or else we will end up with a very inequitable healthcare delivery in this country.
I suppose like when I was like previously, before I started my PhD, I was interested in myself in becoming a clinician. And in preparation for interviews and such, I learned a lot about, I suppose some of the issues in the healthcare system, one of which I recall being specialty, doctors who, for example, cardiothoracic surgeon, for example, or someone who's cardiology trained, them going to rural areas versus in the suburbs, right, or in the city centres, has always kind of been an issue. How do you think we can incentivize, clinicians to actually go rural? Because that seems to be an ongoing problem.
Yeah, it is an ongoing problem, and I think you're right. It's about all the parts of medical care being available, starting from that principle that we want to have equitable healthcare, no matter where people live. And there's been many attempts to get, the right people into the rural settings. You can't have everything everywhere. Some of the very super specialties are not going to be relevant to, you're never going to be able to have them in remote settings. And look, various incentives have been tried that haven't worked. And these are like financial incentives through Medicare, through the amount of money people can bill, relocation sort of incentives, all sorts of things. And we are where we are. So I think moving forward, we need a more innovative approach, and we're really going to have to look at how we use technology as well as people actually travelling to these places in person where required, but we're going to have to break down those borders. And I think one of the most exciting things is the possibilities that technology offers in terms of getting care to where it's needed. And that may, I would love to think, yes, we would still have surgeons that were willing to travel to go and do their surgery in rural areas and do that in a regular basis. And many, many do, of course, they do. But how do we actually think about the workforce and where we need the skills in a more nuanced way? And then consider how we really start to think about healthcare as a healthcare system. In this state, we don't have a connected healthcare system. We have health services that are independent, that are not interconnected. That's one of our biggest challenges. So, for example, if you need a hip replacement and you're in a rural area, then are you going to wait to have your hip replacement there within, 10 minutes of your home? That might be ideal, that you want to do that, and that would be, for some people, the only thing they would want to be. But for many other people, they may be quite happy to have their hip replacement elsewhere if they knew they were going to get good post-operative care and then get back home. So thinking about how we might open up and better integrate what we already have, I think, is low-hanging fruit. Still hard to do, but we haven't yet done that. And then the culture, I think there's still some work to be done. And we do need to have rural and regional centres where we are actually attracting workforce to go there. Sometimes that'll be money, but because we've tried a lot of that, I think it's more than that. I think it's more about the kind of work environment when they get to the setting, how easy it is for them to do that work when they get there, how well supported they are, how well supported patients are after they might leave. So I think there's a lot more factors than pure what we might think of as economic or financial incentives. And that work is, I think, needed to understand. We often would say it's about we can't get rural workforce because the schools people want to send their children that they imagine having one day to schools in the city.
Yeah, fair
You know,
enough.
all these sorts of things. There's masses and masses of information on these problems that have been amassed over the last 30 years. But now I think we need to take a bit of a step and think of some innovative solutions rather than just, trying to bang on with the same ideas that we've had for 20 years that haven't worked.
I'm curious, there's so many questions I want to ask, but one of the things that you mentioned is that we should probably be transitioning to more of an integrated healthcare system rather than these sort of distributed health services that don't really talk to each other. Would you be proposing sort of like an NHS style system or something else?
I wouldn't. I think when you say NHS, it conjures up either great joy or great despair, depending on who you're talking with, I think. I would start from principles of having the patient at the centre. So I would start from thinking about the healthcare system as what we're trying to achieve is patient-centred healthcare, and that we think about the pathways of care that people need within their life, across their life course, and think about designing the system from there and then moving out. Now, that would be ideally taking the best of all the systems, the NHS system, more of the European health system and the US system, especially some of the health maintenance organisations where they have had more integrated care over a longer period of time in the US. So I'd look for, cherry picking the best of the systems that have been tested, as well as what we don't want to lose from our own system here. It is hard to transform an entire healthcare system. There's no doubt about it. And that's why I think it's a very difficult thing for governments to do as well, because it's not like there's a simple blueprint that you can just implement. And I don't believe that you can just, do a kind of massive blueprint change overnight that's going to work. I do feel that we're going to have to test different innovations. It's going to have to be a bit more flexible, and we should be encouraging people to give new things a go. Have a try, measure, and continuously improve. Don't sort of wait to perfect the perfect model. And then, all the years it will take to implement. There's got to be a bit more experimentation along with careful evaluation and monitoring to get this to get into a bit better than we have now around the challenges with workforce, the challenges with waiting lists, challenges with emergency departments. And we need to be encouraging people to test creative ideas.
Sure.
We have got nothing to lose.
Yeah, that is true.
Because we've got a big problem.
It's a massive problem, absolutely. Why do you think people are hesitant to experiment with new systems?
Look, I think that in the healthcare setting, whilst there's enormous pockets of innovation and discovery and all of those things, there's also quite a large amount of what I might call stuckness. People are stuck in the way that they're used to doing things. And the idea that it would change causes them anxiety, and so you hit quite a significant resistance to change. And I'm sure that, there's many, many, many examples of that. And why is that? When, you think it's people get stuck in the ways of doing things and the cultures that exist within the various settings, and they don't want to change and move in a new direction. And that will be in pockets throughout the healthcare setting. And even though, yet in the same setting, same hospital, you will find teams that are out there testing new ideas, doing things in really clever and new ways. At the same time, you'll find teams that haven't changed for 15 or 20 years potentially in the way they do things. So it's not homogenous within the healthcare system. And understanding the cultures that are there, I think, is really important, and having the tools to help people work through change, because I think that's the other thing, that having the scaffolding, the frameworks, the processes and and things to assist people through change, they're not just at their fingertips. So everyone sort of tries to almost build it from scratch, like they're just starting over, the first person to ever implement it. So I think there's some ways that we could better scaffold and support people through the change process. Part of that starts with culture.
I suppose one of the things that you mentioned earlier on in the conversation is this cultural change that has happened around general practitioners, and that sort of students no longer want to be general practitioners, whereas we know that at the heart of care is sort of primary care. It's very, very important. What do you think have been the drivers of this sort of decline in the prestige and the desirability of the GP profession? And what do you think we can do about that?
I think there's a few things. One is the excitement and advance that's happened in specialist medicine. That is exciting, and so that's attractive. Another thing is the fact that the remuneration for general practice was frozen and didn't increase. So that's pretty obvious if you just stick a pay rate. And the growing disparity between what the GP would earn and our specialty colleagues grew more and more and more over my lifetime. And that gap in pay, when we just talk about pay, between specialist and general GP is very large in Australia. That is, it's not quite like that in other countries. So the UK or in the Netherlands, where general practice is very strong as well, Denmark, the countries where GPs have been as much a part of the healthcare system as in Australia, that difference between GP salary and specialist salary is just nowhere near. So ours grew rapidly and the GP one sort of stayed flat and the others went up.
Are you referring to
I think that's
the Medicare
a part
rebate?
of it.
Yeah.
The Medicare rebate is part of what's driving that, but also the growing complexity of the patients seen in general practice. A lot of the more simple things. The complexity of the general practice consultation increased, and the fee that was received for that didn't alter. And the work that GPs were doing and expected to do and had to do did become more complex. And so all of this together meant that the remuneration for what they were getting, it just didn't make sense because if you were there, you knew how difficult the work was. And so if there was a sort of perception that, that was the easy work, well, that's just definitely not true for anybody who's been a GP. They will know that for sure. That seemed to become a bit of a rhetoric that was the simple work, and somehow the complex work was done in another part of the healthcare system. And so all of this messaging, I think, it's a subtle culture change that was probably there. It's probably been there for quite some time, but just the rise of the importance of specialism within society, it became, very rewarded, and therefore what the generalist role was taken for granted, not as well supported, became more difficult, and then more expected of it, and then people think, well, why would I do that when I can do this, and I don't have to have all of that complexity, and I will even get paid more for doing that, and it will be simpler. It'll be simpler for me to do that than take on all of that risk and responsibility and not be remunerated as well and not be recognised as well. So it's a bit of a no. I mean, more interestingly, when I've spoken to students that are still really, really passionate about general practice, is hearing from them what's driving them to be passionate about that, and it's the work. It's just getting to know people and being a doctor for people over a course of different, over their period of time is so rewarding that the work is fantastic. And that's what drives them, even though they know, hang on, it's going to take me longer to pay off my HECS debt. It's going to be more complicated. I'm going to feel out of depth. I'm going to have to deal with a lot more uncertainty. I'm going to have to hold a lot more risk, but I'm still going to do it. So they're pretty special people. Yep.
Absolutely. I want to propose like an interesting thought exercise. In your opinion, what do you think the perfect healthcare system looks like?
That's a big question.
It's a hard question.
That's a hard question. But I do think it looks like a healthcare system that is values-based. And the values that are there are around having the person at the centre of that healthcare system and having a healthcare system that is really fundamentally based on caring for that person and the whole person and thinking about their care from the whole person perspective. And that would mean, that that's a big thing to say because that's the starting point of the healthcare system that, I would love to design and love. I bet we would all love being a part of that healthcare system. Then I would be very, very clear about the sorts of care pathways that exist in that healthcare system. So I would think about it probably more as a networked society sort of approach, a neural network kind of approach, and think about the important parts of the healthcare system being, the one source of truth for medical care information. So, and when you think about the electronic medical record that might support that, then thinking about how that is brought together. And is that probably now, maybe 10, 15 years ago, I would have said one big mega EMR. Now I think, no, it'd probably be a disaster. But it's about how you bring together the bits of that one source of truth around that person in a way that's interoperable and reliable and secure and is going to support their care. And I would hope that, AI and things like that would be really, really helpful in that regard to keep it as succinct and tight as it possibly could be, and that then they would have a relationship with a primary care provider that they knew was their primary care provider. So it would have like a registration sort of model where you were registered and then you were cared for according to the team of care that you might need. And that would depend, that would mean that you would have a care plan around your needs. And if you had a person with complex multiple health problems, their care plan and their interaction would look differently than if it's somebody who has an acute, episode once every 5 years. But there's similar elements within it. And then I think we need to have sort of better agreement about the referral pathways and the communication channels and the triaging of how we work with people to get them ready for whatever the next step in their pathway might be. I think we can probably learn a lot from the way that things like airline travel is organised and complex travel arrangements are organised and things like that in terms of and banking, how you interact with those different sort of parts of a system and deliver care and have the right person, the right specialist, the right care plan for that person. So a lot of this is around really better ways of better ways of assessing people and better ways of triaging them so they get to the right care at the right time. And it sounds easy to say that you can do that. It's actually very complex because we do have all the parts of the puzzle. We've got all of the players that we need, probably all of them. We may need some more if we really mapped it out. But at the moment, they're not really well connected. And at the heart of that, healthcare would be a team sport. Not that it's sport, but a team exercise. And people would know who the team was for that particular problem. And so it would maybe lose the walls of the hospitals a bit and have things integrated more around where those areas of excellence are and where those generalist facilities are, both in GPs but also in generalist parts of hospitals. And so this is a big debate, of course, whether, you have hospitals that are specialising more in particular things or whether each hospital has everything. Okay? I
suppose it comes back to like the resource dependency.
It does. And the best way to organise it and where the efficiencies are going to be. And how would you start to do that kind of arrangement I would start with in a smaller area. It's very hard to do this at scale, so you need to test different ways. And we're testing different elements of this already. But planning, what would it look like if in the end, 5-10 years down the track, if you could truly organise it around the patient and think carefully about the digitally supported healthcare and maybe more triage around a system versus a very place-based approach where every single health service has its version of everything. We'd have to test it. It may or may not be better.
Yeah, it's very fascinating and utopian ideal, isn't it? So what you've described essentially is one source of truth for medical information, basically a centralized sort of electronic medical records for everyone in the population, databases of all the specialists and all the doctors, and patients are assigned to sort of care teams. You have a registered GP who is responsible for looking after you. You have these sort of care plans where a team of specialists are, I guess, gathered by this system to take care of whatever health problems that you have, and you know who is responsible for your health.
I'd probably have it a bit more pick and choose than that. I'd have it a bit more responsive to your needs at the time, so that you might, ideally, you'd be able to, let's say you needed physiotherapy because you just sprained your ankle, something like that. You'd be able to better find that physio program that you needed for your sprained ankle, and that you would be able to find that in a location that was going to be convenient for you and a time that was going to be convenient for you, and that would be sort of generated and presented back to you, or the doctor or the nurse or whoever was assisting you in that sort of decision-making process in a reliable way that gave you those options, right? And then you would be able to say, yes, I can do this. And ideally you'd even be able to book in and see, they've got a spot for a person to be a part of that group. Or you could have a online version of that, or there might be your sort of avatar version that gives you the coach, the sort of virtual version of that. And you may not need to get to the real life version of that until, you did the virtual version, didn't work, you're still paying, you can't, whatever, those things are. So a lot of this comes down to reliable prediction tools. And they won't be 100%, of course. So, we need to have ways of sorting through when we don't think they're working. But we do have a lot of this capability already. We have the people who know how to build these things. We have lots of data that can assist with making these, but putting them together and putting them into practice and doing that at scale is I cannot, give you many examples at all of where that's occurred. But I think there's no reason that cannot occur. It might have sounded, sort of like a futuristic vision 15 years ago, but it's here. It's right here now. It could be done, and there are groups that are doing this.
Of course.
It's not as common in Australia at this point in time, but I would like to see us sort of leapfrog into that. Because we've missed a few steps of the digital health transformation. So we need to kind of jump and leapfrog to embracing, things like AI and to work for us.
Now, we talk a lot about business and entrepreneurship, but to build the future, you need people and a place to build from.
Discover the perfect workspace for collaboration and productivity. Melbourne Connect Co-working is offering our viewers an exclusive 25% discount on 12-month memberships when you quote ambition in your inquiry. Links are available in the description below. I suppose a challenge has always been creating centralized systems, and usually the players that create really good software that can do all of that sort of stuff, that has the AI integrated, that has that prediction algorithm that's really, really useful. They're usually like small tech startups. And so they don't have access to the government to be able to sort of mandate a solution across the entire healthcare system. They end up creating this like these really good softwares, but they're pocketed. Like they might have certain customers and they're competing against another startup that has other customers. And then the government version of the software tends to be like really clunky and not very useful.
Yeah.
So it seems to me like the solution lies in assembling like a really good visionary like tech team that actually is backed by the Australian government. It almost like operates as a startup trying to solve these problems, but has that final solution implemented across the entire system. Yeah.
Yeah, and one of the things I remember a number of years ago at a meeting in Canberra that we were talking about exactly this, and we can all get our heads around, hospitals and clinics that you need to build them and what they need to have in them, and everyone gets infrastructure. And they even get things that go alongside that. They get, the payment system like Medicare. They get people can understand what an electronic medical record is. So all of that we get. But what we haven't sort of, I think, really articulated that well is the virtual or the world, the digital environment or system that a government might invest in the same way as they invest in hospital, the bricks and mortar of a hospital. They do that, they build that, they pay for it. But this other digital infrastructure is harder for us to see and plan. But my argument is, why is that any different than the built infrastructure, which we don't have any problem with governments building and doing? So is it different? I mean, I'm not the digital expert, so this is my question to people who are. Is it so different that you could never do that? But likewise, they build hospitals. They're not all built by the same company. They're not all built to the same plan. So, is it? I think we just have to sort of realise that a digital infrastructure for healthcare is something we have to have. So
and I think as well, like a lot of people can agree with that sentiment, but it may then come back to the whole, but it works enough now. I don't want to change the way I'm doing it.
Yeah.
It's kind of the cultural thing again.
Yes. I think culture is really big in all of this and holds us back from, doing things. Also, culture drives the really innovative people as well. So we've got both of that happening, and I can, think of examples of that where, and the experience during COVID where people did things different over the space, in 72 hours or 3 weeks that would have been years previously. So, I heard stories of things like where people were doing home visits and they were being very, very creative, and the people that were going and doing these home visits didn't have the expertise maybe to do what had to be done. And so they went and bought Google glasses and just wore them on the visit, and they were, being assisted. And they just did that over, 72 hours when they had to do something that previously would have been really required someone who was registration, and they had to be creative. So I think it is time now for us to really be testing some quite disruptive ideas and seeing where we get, so that we can, solve some of the problems. But we also need to articulate pretty clearly what are the ones we want to solve right now, because there's so many that, people, it's very easy to get distracted, but focus on a particular area and bring some creative minds to it and be willing to do things quite differently and then learn from that experience. So
what I'm hearing is we need a digital infrastructure software company backed by the government to solve the equity and resource allocation problem, and then a robot surgery company to solve the rural-urban problem. And once we do that, we can solve all the problems.
We can have a perfect and ideal, equitable
sprinkle
healthcare
some
system.
AI into everything.
Well, everything is just has AI, right?
I think AI. I think a lot of the other things is that whether there's work around peer workers, lived experience, social, the community supports, the non-pharmacological interventions. There's also huge opportunity in those areas, both for real in-person activities as well as using digital methods of bringing those communities together too. And I think there's some real everything from very simple little things like just WhatsApp groups for people that might have, that you might form over for looking after a particular person for a period of time, whether that's 2 weeks or 2 years. Now, would that be secure in terms of medical information and all of those things? So I think that we need some. I don't think the highly centralised, big, giant government-supported infrastructure is going to work. It's just going to fail, isn't it? I mean, I think we probably know enough to say it probably won't work. But what we do need is how do we have the different elements of the healthcare system able to be brought together in the way around that person so that they then make sense. And I sort of think of it like little icons on an iPad or something, or on a little, something like an iPad.
Mobile device or something.
Yeah, something really small and able to be with the person, that they sort of drag, get their own little 6 or 8 widgets that they use. A bit like your app. You go to the App Store and you get the sort of apps, but the apps you actually use, because you know how you get those apps and then you never actually use those, that you got them all and you think, why have I got it? But these ones would be things that really mattered around that person and help them to get the care they needed. And we're sort of building that. It is coming, but how do you curate that in a way that is secure? And then how do you get all the other people getting the information in the way they need it to do their job? So, the way the doctor needs it, the way the physio might need the information, the pharmacist. So how do we get that so that, is it too much to expect everyone to be able to use a similar portal, or is it just sort of somehow the information is presented differently to the people that need it? And how many different platforms is that you're bringing together? So I think we need some very, very really. I think we need people that are very creative in this space to be very interested in solving the healthcare problems. And I'm not sure they're that attracted to healthcare as much as they are to, say, financial industry, cybersecurity, defence, right? They get attracted to solving those problems. How do we attract people that do that to healthcare?
Yeah, I suppose the reason might be because those industries are typically like tech-led. As in, like, most of the changes in those areas that have happened are because of technology.
Yep.
Healthcare hasn't really seen that to a large degree, relatively speaking. So, what should we speak about now? Let's have a look.
I think the sort of fintech versus health tech issue is that when young startup founders or people that are trying to build businesses want to create company that makes a lot of money, they usually will pick, as you said, like fintech. Or agricultural tech, or all sorts of those sorts of tech-led fields. Whereas healthcare has so many barriers to entry. There's so many people that you have to convince to be able to have your product or service integrated into a patient sort of seeing pipeline. And what I've noticed in a lot of my friends that are sort of health tech founders is they end up often not building solutions that really sort of solve this equity divide that you mentioned. They end up trying to tackle the problem from a totally outsider's perspective. So they end up creating longevity healthcare products that sort of basically offer wealthy people the ability to track a bunch of their biomarkers over time.
Like a competing healthcare system.
Yeah. Or that there might be tools that increase efficiency for doctors through AI and transcription, but no one tackles a problem like digital infrastructure for Australian healthcare system because
Or
Like you
just
have
get
to
shut
convince
down,
the
yeah.
entire Australian government to be like, okay, we will go with you. And if you don't convince them, you're dead. Like the risk to that, the risk of investing in a company like that, just for it to be shut down because like of a government change or the project just being too big to implement and too difficult and complex to navigate is a risk that most people aren't willing to take.
Yeah, absolutely. I get that for sure. But I think coming at it from the patient perspective, that's where it then gets, who pays? So you come up with this great set, this way of navigating the healthcare system and curating your information and doing all of the things that you need to do. So who's going to pay for that? That's the question. Well, a mix of the person and potentially the government, and perhaps that's the way to think about it, rather than thinking about the government kind of leading on the development, but actually would they contribute to the cost or to the payment for the person? Why not? We're in a very why not? Why not have that as a way that you can receive a rebate for those things? I mean, there are different ways of thinking about how to fund it, but I don't know that there's an example of where it's yet. I think this is very. People are very aware of the need for us to think about the financing models for these sorts of initiatives, the digital support of healthcare, and we'll start to see funding mechanisms for that. We have to, in the same way that we see the way that we decide whether drugs are funded or not, and whether there's rebate, whether they're reimbursed, and different sorts of interventions. This needs to be done as well for in the digital healthcare world. It just hasn't happened yet. I think people realise that it has to happen, but there isn't a way of doing it easily yet. It must be coming because we know that the digital support of healthcare is the future, so that it will have to come. And I'm sure that you will see it in your medical lifetime for sure.
Hopefully. So I suppose incentivizing patients to remain healthy or at least like a reimbursement for keeping patients healthy rather than reimbursements for like labor and services might be a good place to start as well. I'm curious though, just to sort of backtrack to some of the more, some of the areas that you've been researching a lot over the course of your lifetime, which was sort of shared maternity care, cervical screening, and then mental health as well, especially sort of post-pandemic declines in mental health. Maybe you can pick the area that you still think Australia needs the most work in and just explain to our audience what actually the problem is, that maybe they're not really aware of it, and what's sort of being done about it, and what do you think needs to be done about it?
Yeah. I mean, I think one of the biggest opportunities for us is the recognition, the realisation that mental and physical healthcare are just so inextricably linked that they're very difficult to separate. We can separate. We do see them separate when you get to extreme ends of both of those issues. But when you think about how common mental health symptoms are within the community, all the way from young children through to the elderly, you realise that this has to be an approach where we're keeping people well and we're addressing their mental health and their physical health needs. And I would put effort into addressing both emotional well-being and keeping physically well and socially active as being the core sort of things that we need to do at a community level. It's easy to say that, but when you think of the real drivers of mental health issues, it will come down to isolation, to loneliness, to trauma, to all of the many, many social determinants, and the amount of the amount that the problem's caused from some single gene defect or a very strong family history is only a small part of the population that end up having the problem. And so I'm a very, it doesn't matter whether this is in, recent mothers, whether it's in elderly, whether it's in children. I think we have to think about those fundamental needs that people have for human connection, for keeping fit, for having a healthy diet, and for learning techniques to cope with the sort of everyday traumas of living. And these things need to be embedded in the way that we look after our children, run our programs in kindergartens and schools, and the way that people get response through the primary care system and access to different programs and things if that's not organised in their own life. So I think the more and more research and clinical work I've done, the more I would have loved to have been able to refer people early on to these sorts of comprehensive programs that were really taking account of their physical and mental health needs. And I would just have had, dozens and dozens of people every month that I would have been able to send to such programs if they existed. But they don't exist very much at all. And instead, you send people to just get a bit of themselves fixed, if you like, when I think it would be really exciting to be offering some of these more comprehensive programs very early on for people who need them, as well as the prevention side of things. And then, I think the other really exciting part of the whole mental health area is the rapid sort of change that's, the things that we're learning in neuroscience. So, at the other end of from the complete other end of the spectrum of really understanding those brain-mind, the brain-mind-body connection, the influence of the gut microbiome on all of those sorts of things on mental health and wellbeing is another really exciting part of mental health care. And it would be wonderful if, we made some very significant advances and were able to solve some of the mental health problems more easily than having to do it the very, very hard way through lots of different interventions. That would be brilliant. And so I'm very hopeful that some of the work that's underway around those areas of neuroscience and in particular microbiome work, I think, it could be really interesting. And we've got examples of conditions and things that have been elusive and difficult to even imagine having cures that we now have cures for, and it'd be wonderful if we could do that in some of the areas of mental health. But it's still, I wouldn't say we've got a bit of time, a bit of way to go before we get to that level, I think.
Yeah, I think mental health is always going to be a tricky area, especially a lot of people don't necessarily get the help that they need.
No.
Like I probably fall into that category among some others as well. But something that I have kind of outsourced a little bit, and Bren's probably done this as well, is speaking to AI.
Yep.
As like a counsellor. What's your perspective on that?
I think I was actually talking to someone about this the other day, and I can see that there's a lot of benefit for that, in that it can be an outlet for someone to actually get some response as well around what they're saying, and I think that's great. And it's an interesting one to think about how that would compare to seeing real life psychotherapist or psychologist or whatever, and what's the difference?
Well, what do you think the difference is?
Well, I imagine the difference is going to depend. It's probably going to be a lot of work to get the AI psychotherapist to have the level of reaction and knowledge, etc., that the real psychotherapist has. And I'm imagining, and this is like, I haven't really thought about this till now, but I'm thinking that I doubt they've got an enormous amount of psychotherapy sessions, because they're all done in private, that they could train this AI on. I'm just guessing that would be pretty hard to find. Right. I think it'd be pretty hard to find, because it's all very, I doubt Freud was sort of being taped as he went. So it's not like you can find lots of data sources. So I think that would be a lot of an interesting way of doing that. To be able to train the response, how would you do that? And if it's all being done through textbooks and what training manuals and things, I imagine that's how they would do it. Then you're going to get to a certain level. Would it be the same? I would think that it's not going to be quite the same, and you're going to get you'll be able to find a much better response from the human being right now, a much, much better response from most. But on the other hand, there may be some, you're going to have better value than you might have from some responses you might get from healthcare professionals.
Yeah.
I think it's probably going to fall a bit in the early days. But the other part of it, I think, is that as a human being, people may be even more honest potentially about what they're really thinking and what their experiences really have been. So maybe they're going to tell the AI-generated therapist the truth, whatever truth is, that they might withhold from a therapist, or it might take longer for a therapist to get there. So I wonder if it would prime people well for therapy, and that it might be a nice, interesting sort of step to say, well, would you let your therapist watch the AI session that you had? That's the question. Because they might find that a really useful thing to do ahead of seeing
Consult
you.
or something, yeah.
Maybe it would help support the face-to-face sessions that the therapists are doing. I think it's a really really interesting. I haven't actually tried it myself, but I was talking to someone the other day who'd had a go at speaking. I can't even remember what program it was, but they said it was really believable. They found it was quite engaging.
Yeah, there's definitely some solid programs out there. I think the first that we interacted with was called Hey Pi, which I don't think is even technically supposed to be a counsellor.
Yeah.
But
it's not technically a counsellor, but it definitely
functions
acts very friendly and is insightful and tries to peer into whatever problem you have.
Yeah.
But I've noticed that the curious thing is that you are very right in the fact that no one is, or I'm not aware at least of anyone that's training like a psychology specific LLM for AI counseling, and all the products out there are just like normal LLMs that have just been prompted or instructed to be helpful and to try and peer deeper.
Yep.
And that yes, you could theoretically fine tune a large language model on textbooks and diagnostic manuals and things of that nature. But most of the training of psychologists is actually in the room with the patient, and the sort of feedback they get from superiors on how they interact with that patient and whether they were insightful or helpful or not. So there's someone should definitely do a research study on the difference between the helpfulness of an AI chatbot and a psychologist long term, but then also someone should probably be training or at least gathering data on psychologist patient interactions and compensating the patient. Maybe you have discounted fees if your conversations and thoughts are being used to train psychologists. But you can imagine that if it really does get good and if humans are able to maintain a relationship with an AI that is as helpful as a relationship with a real psychologist, that would probably be very helpful for the population at large.
Yeah, I think this will test the human connection bit of the therapeutic relationship or the therapeutic alliance, because I think that's a really strong part of good, counselling, good psychological practice, and that's a sort of intangible, the therapeutic alliance. And this is why is it that some people have a really strong connection with another person? There's something going on there. So I think this would be a good way of looking at that too, as well as I think probably even a step that might be a interesting entrepreneurial opportunities more around the supervision, because when psychologists are trained, they have a lot of supervision, plus when they're working, they always have supervision with another colleague. And I wonder whether there is a role for AI in the supervision of students and trained psychologists, because this is a very, the supervision, and also not just that, in supervision of medical students and all allied health students. So, the clinical placement hours that people have to do. What are the possibilities for AI generated clinical encounters to count? Would they count? Why don't they count? Why do we, should we, and we're thinking about this with trying to push ourselves around what things look like in the future, but our current model where clinical placement, you go into a real healthcare setting and you hang around and talk to patients when you can, and you speak to tutors and have your group debriefs and things. That is the traditional way that we've trained. What would be the effect of doing that in a virtual sort of clinic where you see virtual patients? Now, would you get the same learning, less learning?
Well, I suppose it depends how real it feels.
Exactly.
Right? I mean, the new Apple Vision Pro came out. I don't know if you saw that. It's like a wearable headset. It's almost like augmented reality.
Yes.
I feel like that has a lot of potential in terms of medical school training and
I think this
patient interactions, sales interactions.
Yeah, I think this is a really exciting area, and I would love, our people to be getting into this and constantly saying, "What the heck? Why can't we revolutionise the way we do clinical placements?"
Just order some. Just order some for Uni
For the medical students, yeah. I'd love to try it out.
Yeah.
Oops.
Sorry.
Another curious thing that I've noticed is just in terms of like the rural and urban divide again, that exists in psychology and psychotherapy as well. We actually ran into a colleague 2 years ago that was using VR and AR to enable psychologists to actually interact with a patient in a digital setting.
Yep.
So you could have a psychologist in the city putting on an Apple Vision Pro and interacting with a patient in the rural areas.
Yes.
And they would also be experiencing like a real almost like a
Feels
real life
real.
patient interaction, even though they're in the middle of a very
Bendigo
rural
or
area.
something, further,
Yeah. Well, I think these are all things that are really exciting in the way that we can think about how we train people and the opportunity that provides, because those sort of, even the more virtual sort of AI generated interactions, those patients are never going to get sick of seeing the students. And you can just see, you could have lots and lots of exposures. And so perhaps you could even be, we could have more practice before you went and saw the real person who's going, so that you get a bit more rehearsal ahead of time or post, or afterwards when you're sort of wishing, gee, I wish I'd done that sort of differently. So I think there's a lot. We should be seeing a lot of use of exactly that approach in training. So what would stop us from that is, who's going to develop it, who's going to pay for it, is there any market in it, all of those questions as to why it probably isn't here right now. Because it does make a lot of sense to me to be doing that and having the opportunity for people to really, really practice. And I think, simulate. We do that with people going into space, don't we? We don't, we don't keep sending them up to sort of on the space observing to get to be an astronaut. No, it's too expensive. So we've had to work it out in settings where it's impossible to just allow them to tag along all the time. But in our clinical training, it still is that very, traditional model. But for how much longer will we do that, and what opportunities does this new world offer? I think it offers us enormous opportunities.
Absolutely. Jane, just out of the interest of time, we might be wrapping it up shortly, but this has been a very fruitful conversation, and I mean, I've learned a lot, and hopefully the audience has as well, but we'd like to ask one last question, which is a bit more philosophical, which is, what does living a meaningful life look like to you, and how do you actively pursue or envision achieving the sense of purpose?
That's an easy question. I think it means having joy and interest in what you do, and it is about those personal connections in your life, and being really, having that sense of purpose as to why you do what you do. If you don't have that, I think change what you're doing, because having that sense of purpose is so important for us to have meaningful lives.
Absolutely.
Right.
Well, we've been inspired. We've learnt a lot. So thank you, Professor Jane Gunn, for coming on to the Orange Podcast.
Thanks so much.
Thank you. It's been lovely to chat and meet you both.
Brilliant.
If you like this studio, you like this podcast and the space that we're in, or if you're seeking a dynamic and collaborative environment to fuel your success, don't miss out on Melbourne Connect Co-working.
They are now offering an incredible 25% discount on 12-month memberships when you quote ambition in your inquiry. Follow the links in the description to learn more.